Awesome. All right. Hi, everybody. Thank you so much for joining us this evening. We'll give everyone just about a minute or so to get logged on. My name is Brooke McGivern. I'm a speech-language pathologist here at Tim's Medical, and I am extremely excited to have Sara Davis with us this evening to discuss all things airway from the SLP's perspective. A couple of housekeeping things before we dive into content. If you are interested in obtaining ASHA CEUs for this event, it is eligible for 0.1 ASHA CEUs, and we ask that you stay for the duration of the presentation and then complete a quick survey. The survey will be open for 7 days, at which point we will submit for ASHA CEUs. So you should see that reflected on your registry within 30 to 45 days or so. If you'd like a certificate of completion, just send us an email at tims-univ@tims.com and we will get that over to you. If you missed any of this information, I will pop it into the chat. And if you're on a phone or something and can't see the chat, don't worry, the information will also be sent out via Zoom. So with that, I'm going to go ahead and hand over the floor to Sara. If you have questions along the way, feel free to put them in the Q&A box or the chat. So with that, Sara, I'll hand it over to you.
All righty. Hello, everyone. Thank you for joining us this evening, wherever you are. It's only 5 p.m. for me, but I know it's later for some of you. So thanks for being here. I'm going to first just share my screen and also bring us into the slideshow mode. 1 second. There we go. Does everybody see it, hopefully? Okay, so I'm going to try to get through a bunch in 60 minutes because this should be covering a lot, but I actually worked on this for hours and hours and hours because I'm really passionate about airway. And hopefully, Rachel, you're telling me you can hear me or see this, so that's great. Thank you. But I spent a lot of time creating this and actually spent way too many hours because I've kind of created a really comprehensive version that I'm going to form into a new course on my website. So I parsed down a lot. It was really painful to do, but this is only 60 minutes, but I hope it gets you interested. And I have a really comprehensive course on all things airway where we get really deep into diagnostics and therapy and all kinds of things from here. But we're going to move on and cover hopefully a ton in 60 minutes. These are my disclosures. And these are the objectives as you likely saw when you registered, so I won't go over them. But our mission is really to cover mostly ILO, EILO, BPD, other airway-related diagnoses, and some therapeutic interventions as well, surgical and more things we do. And then also understanding endoscopy-related findings and how to use endoscopy to help patients understand airway conditions and believe in the therapy as well. And then also several patient cases and videos that I want to get to. This is a little bit about me. You've also maybe seen my bio. So airway-related conditions, as discussed, ILO, EILO, EILO, BPD, breathing pattern disorder, subglottic stenosis, but also posterior and anterior glottic stenosis will be covered, sarcoidosis, amyloidosis, mucous membrane pemphigoid, MMP, and a laryngeal version as well, obviously, lower airway obstructions, asthma, irritable larynx syndrome, laryngeal hypersensitivity, cough hypersensitivity syndrome, now CHS, also called chronic cough and chronic cough refractory syndrome, etc. And then posterior glottic insufficiency, or PGI, also called PIPI, which again, we'll get into all this. And we're also going to talk about, again, cases, but what else? There's several other things that can impact airway. So in a nutshell, yes, therapy is going to be helpful, but it really depends what's going on, and likely the chance some of these things may need surgical intervention first, and we will certainly cover it. But airway therapy in a nutshell might include recovery breathing techniques, LOB techniques, Buteyko techniques, breathing pattern training, education, just general improvement of the laryngeal environment, training awareness of physiological precursors to airway episodes or cough-related episodes. This is included in airway. And again, these therapies for these conditions, they work. And honestly, if the patient is persistent and consistent, 1 or 2 sessions should be very helpful. Now, again, breathing pattern disorder or something that's been present for a while could take a little longer, but more ILO, EILO it's pretty quick that we make these changes as long as the patient is consistent. It's also with cough, those kind of airway conditions as well. But as mentioned, surgical intervention could certainly be necessary. So you guys all likely know this, but normal breathing function at rest, you know, the vocal folds, the whole larynx, it's kind of multifactorial. And I like to say caveman or cavewoman status. The main job of the vocal folds is actually to shut. It's to protect the lungs. And so as we know, for swallowing, that's supposed to happen. For voicing, the vocal folds vibrate because of air below them. And then also for breathing, they open and close. So those are the biggest things that the voice box region does, as well as cough. And that is a protector at its cavewoman or caveman status. The roles of the larynx, as discussed, gatekeeper, protector, that is number one. And at the root, that is the purpose of the vocal folds. Respiratory modulator, production of voice, cough, swallow, etc., as mentioned. But we want to keep this red one in mind because this is often what leads to a lot of these airway conditions we're going to discuss. So, EILO. In general, this is an inappropriate, transient, reversible narrowing of the larynx in response to external triggers. It has been called VCD, PVFM, many other things, PVCM, there's lots of things, but now the new term EILO, Inducible Laryngeal Obstruction, kind of is more inclusive of the vocal folds, but also everything above them coming inward, and again, in response to a trigger in most cases. It's complex, and it really does require skillful differential diagnoses, and we need to acknowledge the role that this differential diagnosis plays in really truly helping these patients, because they can go misdiagnosed as something else for way too long. So the Delphi study, which was in 2023, there were a lot of professionals around the world that came to a conclusion of what EILO definition was. And again, it is inappropriate, transient, reversible narrowing of the larynx in a compatible clinical context. The patient has symptoms, and it's in response to triggers. So most patients with EILO have already had extensive medical-related workup. They often don't even believe an SLP will make a difference. EILO occurs through the lifespan in young children, through the elderly, but the greatest incidence is within the adolescent and adult age groups, and that's about 4 to 8% of the general population. 25% of adults with EILO have co-occurring asthma. And it's really important to distinguish between EILO from an environmental trigger and angioedema as related to an allergen exposure. And in most cases, patients with the angioedema as related to allergens, they're more likely to report a complete sudden loss of voice and difficulty inhaling and exhaling. EILO patients are less likely to present with that complete loss of voice. Just a side note. It may be considered on the continuum of an irritable larynx patient, or now again, cough hypersensitivity syndrome patient, chronic throat clearing and chronic cough, milder forms, and laryngospasm as a more severe form. Most patients with EILO will have what is described as a functional disorder of the larynx related to its role in upper airway organ responsible for protection. And remember, that's at base function. So truly, and to be honest, I don't know if anyone was at the upper and lower airway conference this past June at UPMC, but Jackie Garner-Schmidt, who is one of my favorite speakers, she gave a wonderful talk about this and how the main role of the larynx, as we know, is protection. And it was on EILO and psychology and how truly is something really wrong, or are our vocal folds doing their job in protecting, right? We believe they're being overprotective, but if we go to the base, their job is to protect. And that's kind of where this condition and cough hypersensitivity stems from. The laryngeal, what's called chemoreflex, can become hyperstimulated even when exposed to benign stimuli, and this can result in EILO. These are common triggers, as we all might be aware of, often involving odors, allergens, temperature changes, humidity changes, air conditioning coming right on you, smoke, stress, reflux, postnasal drip. There's all kinds of triggers. To be honest, I even have worked with patients someone, the trigger was an elevator, and she had to take an elevator every day to work, and that was a problem, right? So we worked through that and had her start her techniques while she was driving to work, as she parked, as she walked into the building, as she pressed the button on the elevator, the whole time she was on it, as she got off, and eventually it dulled that hyperprotective response, and she didn't need to do it any longer. But the triggers are very specific to the patient, and so it takes a lot of investigation to truly figure it out. But there are certainly common ones. This video is a good one that I caught of a patient with EILO, and it is starting with her using voice. It's a stroboscopy, but right here is her inhale, and as you can see, everything is coming inward, which is the opposite of what it should be doing. And then in real time, we worked through this via techniques, and we just did a double sniff. Her chair was turned. She was watching the whole exam. I was going nuts because she hadn't been able to control her breathing, I don't think, for a year. This was the first time I met her, but we worked in real time through this. And she kept doing double sniff he, and viewing her own airway. And I had to guide her to stop because she was so excited she could open her vocal folds. So just an example of being able to catch it and work with the patient in real time, which is so valuable. This doesn't always happen, and that's a-okay. I often, and I'll talk about this later, but I will do exams with patients always, and we'll do breathing techniques during the exam and watch what those do so that they don't have to just believe me, but they'll believe with their eyes and their brain because they've seen it, that when they do certain techniques, they know the effect in their anatomy, which is super important because when you add stress and triggers and sometimes panic and a feeling of this, you want to believe that it works. You can visualize that visual that was provided with the endoscopy ahead of time. It's also good to, during the exam, have the patient mimic the sounds or the feelings they might get when they're having that attack or feeling, because then that might correlate to something on the inside and what it looks like. And then again, have them work through it using techniques as well. Oop, hold on one sec. These are just some pictures on the left of obviously what we're going for, which is an open in the airway. And then on the right, these are more paradoxical or backwards movements of what's supposed to happen on an inhale. So EILO is occurring on the right two pictures. So history is incredibly important, and so are all the details in these airway patients. So these are examples of things you do want to be asking. When the symptoms started, they need to be described by the patient in detail. What are their triggers? Do they even have any? Are they aware of any? Do they feel it on the inhale or the exhale or both? Around 40% of people have both an airway condition and maybe an asthma or a chest-related condition? Is there tightness in the throat or the chest or both? Does an inhaler help? Is resolution of the episode quick, under 5 minutes? Or does it take longer to recover, over 5 minutes, but up to 20 plus minutes? Is there a sound associated with the symptoms? Can they mimic the sound or the feeling, as mentioned before? Does anything improve their symptoms? Has anyone ever visualized their larynx? And it's very, very important that they do it too. So baseline testing, essential, we need laryngoscopy or video stroboscopy. We want to rule out obstruction and stay tuned for a lot of case examples. We want to rule out mobility impairment. And just a quick case, I was helping a girl who was assumed she had EILO. She had reportedly already been scoped, and I just saw her for the eval, and it wasn't a day I could scope because the laryngologist was in the other room. So I just did an eval and taught her some basic techniques and discussed EILO and EILOBI techniques with her, etc. But I made sure the second time that she came, I could use the scope, and we did some of the techniques with the scope. And she was seen by a general ENT first, but when I scoped her, she had a vocal fold paralysis, and this was a new finding no one knew about, and she was a college tennis player, so that prompted imaging and further workup. So it's just really important we take the time, even if a laryngoscopy's been done, it's just really important to make sure we really test out mobility impairment and obstruction, and again, teach the patient with the scope provocation testing to visualize, troubleshoot, and work through events. Visualizing without provocation in real time, like I said, as biofeedback, even if there's no episodes captured, which does happen a lot, we can still have a lot of value in doing the scope and working through things. recovery techniques, EILO techniques. The first time I meet somebody, I teach them EILO really quick with the scope in, even though they're probably not doing it right, but I just want them to kind of try to feel it and watch what happens. And in most cases, we see a really beautiful double inhale. And again, that helps them buy in and helps them understand. Laryngoscopy changes the diagnosis in 67% of patients, which leads to a change in therapy, treatment, ideas, and biofeedback. And the benefits of scoping is so, so important. So just like the tennis player example, truly avoiding this is a disservice to the patients. Even if they've already had cardiology, pulmonology, GI, all these other people, even if they've had ENT, sometimes it's, I mean, in my opinion, always it's really valuable to use the scope for biofeedback if you have access and if you're able to do exercises with the scope. And then side note, I learned this at one of the more recent airway conferences. You can have EILO while sleeping. And how we diagnose that is drug-induced sleep endoscopy. It's called DICE, and they discussed that at the conference. It was interesting. Often already completed, but important, as discussed, is PFTs, pulmonary function testing, GI-related testing, cardiology, different CT scans, many other providers too, to be honest. So there are mimics for EILO and EILO. Extrathoracic obstruction, stay tuned. BPD, as discussed, laryngeal edema, edema, and anaphylaxis, and that's kind of an airway narrowing related to allergens. Laryngospasm, we'll talk about it. Panic attacks, more rare. Respiratory laryngeal dystonias, exertional dysautonomia, diaphragm flutter, mast cell activation syndrome, many, many things. Again, in the course, we go deep into all these. We just don't have time today. So these are some patient-reported outcome measures for airway. To be honest, when we go to EILO, there's another one called the EILODI, which I'll show you. But for all patients that have airway-related symptoms, I usually give the dyspnea index and the PVFM questionnaire, along with the VHI-10. Depending what's going on, I may involve this one here in the middle. I also could involve some laryngeal hypersensitivity and or cough scenarios. There's a lot that we could use related to PROMs. EILO behavioral treatment. So airway-related therapy with an SLP is the cornerstone for EILO. 95% of patients treated with therapy are able to control their symptoms if they truly have EILO and only EILO. Education, including the scope with biofeedback, as mentioned. Normal versus abnormal anatomy and function, so important. Ways to improve the laryngeal environment. Awareness of triggers, sensory observations, the importance of substituting more optimal motor patterns. Responding immediately upon recognition of the first sensation, hopefully prior to an EILO event, to reroute and maintain prior to an actual episode. And immediately in the presence of possible triggers, even before an actual sensation, prior to any sensations or events, to reroute and maintain. The elevator example, we were doing this before she even was in the building. She was doing the exercises and then through. If in and / within an event or episode has already occurred, you want to respond immediately with a friction-based exhale and rerouting, maintaining at least 10 cycles of a certain recovery breathing technique that proves helpful for the patient. So again, the course will go a lot deeper into this, but just in a nutshell, there are recovery breathing techniques that we would choose for EILO. There are so many options. The value of using the scope will help the patient to see which ones could be more beneficial for them. Also, which ones they feel more helpful than others. Sniff plus pursed lips, sniff plus S, sniff plus SH, sniff plus straw exhales, ideally a skinny coffee stir size straw. Pursed lip inhale plus a pursed lip exhale. That's for more smell-related triggers. Because if you think about it, doing a sniff, we know opens those vocal folds beautifully. But if, the person's trigger is a smell or a scent, and then you're telling them to sniff, they could certainly smell it more. So in those cases, we encourage pursed lip in, followed by pursed lip out. And the fact that you're finding friction is a positive. We'll get more into what that means later and why. You can do a double or triple inhale. And again, this is all kind of trial and error with the patient to see what feels best for them. But if they really feel like this, sometimes is helpful. Sometimes is helpful. Sometimes I have one patient that prefers a triple inhale. But when they do multiple inhales, even though they're quick and in the nose, you want to guide them to reduce any, obviously, shoulder movement. So you don't want this ever. You want the shoulders relaxed. And you also want to notice, are they sounding like they're in their throat? And even though you're telling them to sniff, they could still sound when they're sniffing. The video I showed you of the lady earlier, her sniff sounded like a stridorous sound. So redirecting them to the nose, sometimes it's as simple as if they're sniffing like, and they can't understand it's actually in their throat. If you say, put your finger under your nose, that brings it up to the nose again. And they do several reps, keeping the finger there to connect to that sensation. And then they've redirected the focus, which is so important. Pulsing the exhales to maintain focus and friction is so important as well. This could mean for cough as well, cough control breathing, which we'll get into later, but that could mean instead of just if the air irritability and or the cough irritability is too intense and the patient can't prolong and hold it, and they're more like and they're trying really hard, but it's really hard to do, then you can pulse those exhales to maintain the focus and keep the attention on the pulsed friction-based S sound. So the air and that direction is up and out always. The friction is felt here. The value, as it mentions, of feeling friction, it actually creates a back pressure that opens the airway. And again, secondary benefit, the patient feels it, so it helps them direct it up and out instead of dwelling in the throat. But that back pressure idea that opens the throat, that's an excellent thing to tell the patient because they want an open throat, and that's why we want them to feel friction. So example, like an SH, shh, provides more friction than an S or pursed lips. The skinny straw often provides the most, but that's the purpose of doing it with a scope if you're able as well. And the value of starting with an exhale. So if the patient is already can't breathe and you're saying sniff, 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 but they're like, and they're trying to, but it's so tight in here, using a friction-based exhale to direct that breath they're holding is so important. So there is value of starting with the exhale first. And you're using a friction-based approach, sending the air up and out, and then you're getting a good inhale where you're not having a breath holding pattern. So that's often a valuable suggestion for patients. Respiratory retraining in general is helpful for these patients and for breathing pattern disorder. Pattern training, full body and 360 awareness, nasal breathing, awareness of breath holding tendencies as mentioned, and then what to do next to reset during the scope with biofeedback as available to increase self-efficacy as well. And practicing consistently, persistently, 10 cycles every hour is what I often recommend, telling patients that it'll take 1 or 2 minutes. So it will not take them long, but they need to be consistent. Worst case, they're resetting their breathing every hour, which is excellent and always a good idea. It also, which is the best case, it makes them a pro. So if and when they need it, they're good, they know what they're doing, and it just gets them in this training mode, which again, it's 1 or 2 minutes. It's motor learning, that's the high repetition. And then desensitization training. So this means if a scent or something that we have access to is the trigger, it doesn't mean spray the room and start doing the techniques. It means go outside the room, spray it on a tissue, bring the tissue in the room and start the techniques because you have just a little bit of that scent. You're not overwhelming the patient. So that's a good way to begin that training of desensitizing. So very brief rundown of ILO right there. Laryngospasm, next little thing here. You likely know what this is. This is when the vocal folds completely shut involuntarily or in response to something, right? This can cause stridor. It's an immediate onset. It typically resolves in less than 60 seconds. Some people can pass out, and there should be no real warning with these. It can be immediate, but it also can be more predictive if it's caused by specific triggers. Reflux and anxiety are common with this because, again, caveman status is to protect. Vocal folds always want to protect. So that's what they think they're doing. And I like to tell patients this, so then they know it's not their fault. Their vocal folds are doing what they think they should do, which is protect. So something to keep in mind and tell your patient about this too, is that if you just said, hey, hold your breath, just told a patient, hey, try to hold your breath. Likely, in most cases, we can all probably hold our breath for 30 seconds, right? Or close to it. So the quicker someone that has laryngospasms can realize that, the quicker they can actually relax, because we do have control. And in this scenario, the vocal folds do shut, but they do relax. And actually, as humorous as it sounds, when this is a really scary situation, it helps to calm. It helps to calm the vocal folds, the larynx, the body, the mind. The more relaxed, the better. And if a patient, again, needs some assistance believing that, guide them and say, hold your breath. Okay, look at you. You're holding your breath. You have that control. And then kind of help them realize they will survive, right? Without panic. So keeping that in mind. At one of the airway conferences I mentioned, I think this was the first one in Denver. An idea was brought up about, is MT dyspnea another phenotype of EILO? So we know MTD, we know now MTDG, but now there's this idea, is shortness of breath driven by inefficient coordination of muscle systems, airway complaints worse with talking, but there are no voice complaints? So it's just an interesting thought to ponder, in my opinion, because there is probably some merit to that, because certainly working with these patients on voice does help things, because often these airway patients can be using a backward focused placement of the voice. Air hunger too, getting inability to get a full breath in, air transfer, airflow that gets worse with talking, airflow that's worse by the end of the day, not worse with exercise, it lasts long periods of time, etc. So just an idea, but I thought it was interesting. Okay, here we are now to EILO, EILO, exercise-induced laryngeal obstruction. So this is basically EILO triggered by exercise, and I'm talking high-intensity exercise. The perception of airflow obstruction is at the level of the larynx, and the best way to diagnose this is CLE, continuous laryngoscopy during exercise. I'll show you some videos of that in a second. The most reported symptom is dyspnea, obviously, but there are some other ones that go along with this. 2-to-1 prevalence in females. O2 sats remain stable. And the prevalence is, adolescent population, but 35% in athletes. The International Olympic Committee now recognizes EILO as a significant contributor to breathing problems during physical activity. So something to keep in mind. Also at the bottom of this slide, Denmark and Norway now have formal diagnosis codes for EILO and EILO, which is something we need, because although we are using codes that describe airway dysfunction or the old school code for vocal cord dysfunction, wouldn't it be better if we have EILO and EILO codes? So 25% of patients with EILO also have asthma, and sometimes it's even upwards from there, but that was in these two studies that I have slided. So patients with EILO, common co-occurring diagnoses are often asthma, allergies, breathing pattern disorder, and anxiety. Reflux is actually less common based on these studies. So it's important to examine, test, treat, examine again. Use that as biofeedback, help the patients understand via their eyes, their brain, keeping that in mind. This video is from the first airway conference that was at DU, Denver, really pretty campus. I'm just gonna show you a few videos from here. A lot of the people involved are global. Norway, Denmark, Australia, the UK. GLO is a global organization for EILO. And at this meeting, we established that organization. It was pretty cool. This is a scope of CLE. I'm not sure if you caught that, but there was an inward movement. Here you can see Dr. Todd Olin is showing CLE. Someone has the helmet with the scope. And obviously she's not having an episode, but this is kind of the setup if you're able to achieve CLE, which you want the patient to achieve a high intense exercise. This guy's pretty cool. He's from the UK and he does a lot of training with Olympic athletes with breathing pattern disorder. But again, there's a little video again at the end with some CLE on the bike. They often do it on the treadmill and the bike. But just wanted to show that quick video. Here again on the left, we have some walking. This is CLE as well, continuous laryngoscopy during exercise. You'll see as she increases speed, The arytenoids will have some prolapse, some adduction of those arytenoids.
No.
And this is identified as EILO because there's a laryngeal obstruction as related to exercise. And then she slowed down in this moment because she was feeling very uncomfortable. Now, what's crazy, CLP is continuous laryngoscopy during provocation, as we discussed. So again, that would be more related to triggers. But then CBE, continuous bronchoscopy during exercise. A doctor also from the UK, this video I think is pretty cool and crazy. He's doing a bronchoscopy during exercise.
I do that and explain to people that videos, and they say, that series sounds horrible to have a straight in the back of your throat. I say, well, try having it in a trachea.
And if you couldn't hear what he said, some people say CLE is horrible, and he just said, try having it in your trachea, or he said trachea, because he's doing a bronchoscopy during exercise. But this may be the only way we catch something called EDAC, which we'll talk about later, but it's an excessive dynamic airway collapse that is often only captured during high intensity exercise, and it's further down in the airway, so the CLE wouldn't capture it. So really cool stuff that, again, we might not have access to. EILO versus everything else. So don't assume EILO is the final diagnosis, EILO or EILO. Keep digging, right? Look at on the right, all these conditions could also be going on, right? So really using, like we discussed, the differential diagnosis is so important. And it's important also to have CT imaging with inspiration and expiration. So history, as we discussed, is so important, as we discussed for EILO. But now when we add EILO, there's more questions, right? Where is the restriction felt? Is there difficulty moving the air? Is there wheezing? What does it sound like? Can you imitate it? Is there repeatability of symptoms? Do you have a recording? How long does that last? Is there shortness of breath? Is there chest pain? Is there a cough and throat clear? Is there dysphonia? Any changes in weight? During what type of exercise does it occur? Is it after a certain amount of time? How long does it last? How do you recover? Do inhalers help? Questions don't stop. And so the stuff the patients tell you up front is probably the most pressing information, but it is so important to dig deeper. There's a wonderful article by Sandage et al., and there is a differential diagnosis chart in that article that looks like this. So here's the EILO, Exercise-Induced Laryngeal Obstruction Dyspnea Index, and I'll always give these to my patients who are upper airway but related to exercise, and that is easily accessible as well to use with your patients. So again, just because of time, I'm going to go through this really quick, but EILO treatment is similar to EILO because it's behavioral, but we are very much focused on high intensity exercise, and adolescents often resort to being less active. The most common response with doctors is inhaler. However, they often do not work. Behavioral therapy focuses on low and high intensity, but EILO techniques are only with high intensity. The low intensity, we might focus a little more on respiratory training, breathing pattern disorder training, and which is still beneficial for high intensity. But if we want something like the video showed, all that arytenoid prolapse, those conditions of EILO, right? The EILO techniques help that in high intensity. This is a nutshell of what EILO is. Just because of time, we don't have as much time to go through it, but it is 7 steps that are really focused on providing the patient a double inhale to be done every 4th breath or as needed. And there's a lot of detail that goes into this, but there's also variability that you can use depending on the patient and the sport. This is a really good visual that is put out with National Jewish Health, who are known for these techniques and did most of the research on this. But that arrow on the very right shows that breath 3, the exhale is the empty breath, and that's often that is the one right before the double inhale. But that is often the one that we say in sport, it's good to identify your exertion, because that is a great place to put your empty breath. If for some reason you can't do the 4 breaths in a row, identify the exertion. It could be where you shoot the ball, and that would be your empty breath. And as you pivot to keep running, you're doing your double inhale. So we kind of guide patient depending on sport. The goal is to prevent the breathing problem completely. The patients start the breathing recovery techniques before the obstruction occurs to bypass the attack. So we use those 4 breath sequences. But of course, if the patient feels that symptom, they know what to do, right? They need to be aware, though, of the physiologic perceptions, the pre-obstruction trigger feelings that signal the event is coming, and they need to apply this to sport-specific tasks. This is a great info handout about different sports and how we can alter a LOBI or other breathing techniques for the sport. And sometimes that applies to if there are mouthpieces required, example, field hockey. What can we do? Do we need to alter lip or tongue placement, teeth placement, etc.? Other things to know about EILO, basically, medical therapy, SLP therapy, Botox or laryngology intervention if necessary, which could be related to that arytenoid prolapse, redundant mucosa, epiglottic changes or retraction. Maybe there's value in surgically tethering the epiglottis, depending what's going on. I know that does present changes occasionally for swallowing. So there's a lot of discussion if there's ever any surgical decisions, behavioral health, social challenges, and also mental skills. Erica Westhoff is a wonderful sports psychologist, and she was at the first Airway conference. That is her website there, and she has a support group for EILO patients, and she works with a lot of young athletes, teaches mental skills training to cope with this and how it kind of hugely affects the lives of these athletes. As mentioned, this is now a global organization, and you can sign up to be a member for free of GLO. So as mentioned, excessive dynamic airway collapse, or EDAC. Again, this is usually only found with bronchoscopy, but if there is exertional dyspnea and this weakening of the airway over time can lead to that airflow obstruction. So just being aware, there could be more to the story if EILO is not fully visualized. Even if you're able to get a CLE, there could be something going on further down. And there is a tip or a trick here that I think is great, but asking the patients to tilt their head down and to the side can help you to visualize the trachea a little better. And going hard for lower airway disease in people with expiratory wheezing. So again, if that's that symptom, we want to look maybe a little more into the possibility of EDAC. So again, differential diagnoses, asthma versus EILO. There's definite differences. Inhale versus exhale, stridor versus wheeze, throat versus chest tightness, rapid onset, gradual, rapid recovery, gradual, inhalers being effective or not effective. So keeping this in mind, breathing pattern disorder, dysfunctional breathing, inefficient breathing patterns, sighing, asynchronous breathing, hyperventilation, thoracic dominant breathing, air hunger, breath holding. These are the common symptoms. And there's so much value in Buteyko method for treating this and treating a lot of things, in my opinion. I'm not sure if anyone is trained in Buteyko, but I think it's highly valuable for our work, especially with airway patients, and especially when with breathing pattern disorder. There is a lot chemically that can be negatively impacted by our breathing, right? And there's a lot of detail that goes into this, but Buteyko really works on CO2 tolerance, which does help us get better oxygenated blood to the brain and the muscles. And there's so much value in possibly sprinkling in this in our treatment with patients. I really believe in Buteyko. SLPs can still help, and there's a lot of value in therapy. Assessment, CPET, cardiopulmonary exercise testing for BPD. There are a variety of questionnaires out now and assessment tools, and however, observing at rest does not reveal the problems in the exercise, so we need to test in high ventilatory tests. And there is a new assessment of BPD established by Claudio Milstein, and it's called the Milstein Breathing Pattern Assessment Index, and I highly recommend you guys checking this out and you really just need a phone. The patient's phone is awesome because they can then look at it later as biofeedback. The treatment, again, I'm going quick because I want to see you the cases at the end, and I know time is flying. So checking breathing all day long, tons of reps, motor learning, muscle memory, respiratory retraining therapy. BPD is more abdominal 360 focus, EILO, more respiratory and laryngeal control therapy. Long-term effects of respiratory retraining and research are significant. So keeping that in mind, resistance training is so beneficial for BPD. This could be with devices or hands, belts, stretchy bands, straw breathing, metered expansions. Pursed lip inhale is a variable resistor, and the diameters of straws do make a difference. And visuals and kinesthetic tools are so important. This is a great video of just the diaphragm movement. For the sake of time, I won't show you, but the diaphragm is directly connected to the vagus nerve and communicates with the parasympathetic nervous system, which is more rest and digest. And a lot of these patients are living in fight or flight, which is sympathetic. So it's so valuable. Nasal breathing, diaphragmatic breathing, abdominal 360 focused breathing. Efficiency. It's really important that we also focus on stretching. We cannot expect the whole thorax region to expand if we're super tight and we have a lot of tight tissue, tight fascia in these regions. So stretching is really important, and breathing into stretches and finding expansion. Number one marker of longevity in life is lung capacity. And so finding all the ways we can, exercise, breathing techniques, resisted breathing training, stretches to expand lung capacity, stretch that fascia is so important. And that directly correlates with length of life in years, which is really cool in my opinion. We can do a lot to help that. This is some recommended reading for you if interested. They're really great books related to breathing and airway. In my opinion, there's a lot of Buteyko foundations in some of these as well. And so now let's briefly just jot through some pictures and cases. Subglottic stenosis. Glottic stenosis is narrowing of the larynx, subglottic obviously below the vocal folds. Longer length of intubation will increase this risk. Posterior glottic scar banding or webs tend to cause symptoms of dyspnea. Anterior scar banding will cause more symptoms of dysphonia. And often, again, webs can be present. Some things can look like bilateral paralysis, but it's really posterior glottic stenosis, PGS. So again, subglottic underneath, posterior is at the glottic level, but at the top of the screen, back of the larynx, anterior, bottom of the screen, front of the larynx. Most often, this could involve prolonged intubation, but also other conditions, including Wagner's granulomatosis, which is if you learn nothing else, also know that if they have idiopathic subglottic stenosis, there should always be a biopsy done because they could also have Wagner's, and that's more information to be known. So keeping these things in mind, sarcoidosis, details here, but I'll show you a quick video. This is a patient with sarcoidosis, granulomatosis inflammation with systemic illness. And obviously, as you can see, some worse than others. This certainly affects airway and often voice as well. Again, just time. I'm going to keep going. Amyloidosis, also something that can affect airway. Extracellular deposition of insoluble fibrillar proteins, amyloids. It is rare, and laryngeal amyloidosis, this example here, is really uncommon, but we see it all the time in the clinic. You can see it affects vocal folds, infraglottic region, subglottic region as well. Certainly airway. And this case I would love to discuss longer, but I personally did not know much about this condition at all. Mucous membrane pemphigoid, and it's called laryngeal MMP if you see it in the larynx. It's rare. It's an autoimmune condition. There's a lot of mucosal blanketing, blistering, ulcerative lesions of the mucous membranes. Laryngeal manifestations of this occur in 5 to 15% of cases. They're extremely rare in 1 in 10 million people. But we had a case in January, and I made a really cool video. And I want to show you something on this here page there at the bottom about rituximab is a medication that's been shown to improve MMP in the larynx. I'm going to post this probably here this week on Instagram, but I'm going to try to show you quickly this video. So this was what I saw, and I'll kind of narrate. You can see the arytenoids moving underneath. There's a lot of blanketed mucosa, and I was realizing, oh, wow. We see no vocal folds. We barely see an airway. This woman, poor woman, has a little hole. She was 80. She'd been like this reportedly for 10 years, sounding stridorous, never had been scoped. So I was realizing, okay, I need to get in that hole and see what her airway looks like, see what her vocal folds look like. And you will see As I mentioned, you can see her rytenoids, but so much supraglottic stenosis, can't see too much else. I'm going to skip ahead. I wanted to take a look, and I stuck my scope a few times in that hole and was able to see the vocal folds, the airway. I was helping her through some breathing techniques as well to keep her calm because she was a little nervous. It was hard to kind of get around all that mucosal blanketing, but we got some decent views. And as you can see, underneath it looked decent. I discussed the case with both the laryngologists I work with. And long story short, they were wanting to do a trach just for airway, to preserve the airway. They were thinking either sarcoidosis or MMP. During the surgery, though, they avoided a trach, and she got a lot of other things, and including steroid injection, biopsy, laser of a lot of that blanketed mucosa. And then she was back in, the biopsies were inconclusive regarding MMP, but there's no evidence of sarcoidosis. Patient was referred to dermatology for that MMP workup, wanted to do an oral biopsy soon. Now this clip is the next scope, which obviously looks lots better. The laryngologist did this one. We're seeing a little ulcerative stuff, but way better than before. And then still working on biopsies. I helped him with a biopsy that day in the clinic. Now this was March 31st of this year. Obviously she looks so much better, and it's wonderful because she can breathe now, and she'd been living with that for 10 years. So finally we got an oral biopsy, and she was diagnosed with laryngeal MMP. And again, it's so rare. So I really educated myself on this diagnosis because I hadn't heard too much about it. And she's breathing well now. She's having some more ulcerative stuff in her mouth. So she does have a lot of pain. She's also, unfortunately, having trouble with coverage for the recommended medication. So that's unfortunate, but we're helping her with that. And I just thought that was a pretty interesting case because, again, not something you see every day. For the sake of time, I'm probably just going to mention there are lower airway obstructions, there is asthma, there's exercise-induced bronchoconstriction, exercise-induced asthma. Essentially, that one is really misdiagnosed a lot of times for EILO. So there's a lot of that differential diagnosis, so important. And here's a few other videos here. The importance of not misdiagnosing and really taking time to parse out the different conditions, learn all you can about both, and try to get the patient the most accurate diagnosis. We know COPD is another airway-related condition. Bronchiectasis, another one, maybe we don't see as commonly. It's more often in the elderly and females. And there's a lot on here about cough. I'm very passionate about this as well. But we just don't have the time. So the big thing to know is some believe laryngeal hypersensitivity syndrome or irritable larynx. There's an umbrella here with those two things, or that same idea that could include everything we've talked about thus far. And so it's kind of, they're more the raindrops coming off of this main irritable or hyperprotective umbrella of the larynx. So whatever raindrop you see the patient for, what can you do? You will make a difference in these patients. And so 40% of people do experience co-occurring conditions. And related to this treatment, the patient needs to feel the urge to cough and not cough. And that includes throat clearing, and that is magic. And so that is where the magic occurs in this BCST, which is behavioral cough suppression or substitution therapy. It's consistent, it's persistent adherence to this that makes a big difference. And the patient, side notes, for the sake of time, I'm just going to tell you this. If you see a patient going before they cough, they have enough what's called interoceptive awareness to cover their cough, that they do know it's coming, even if they can't verbalize that to you. And so they have enough interoceptive awareness to change the pattern to something more positive. Even if they don't, we can help them get there in the therapy. So going quickly over things that are often recommended to improve the laryngeal environment and exercises to help cough control breathing and recovery techniques. As mentioned, the posterior glottic insufficiency, PGI, this is often related to intubation. Here's a picture of it. As you can see, this is upside down. This is the surgeon's view. This is really important for in-office bronchoscopy. if we're seeing a patient for stroboscopy and there's so much squeezing AP anterior posterior that we barely can see what's going on around the vocal process regions, we could miss this clefting, right? Because there's so much squeeze. That's the value of in-office bronchoscopy. And this unfortunate problem is big in the ENT world and laryngology world now, after a lot of people have been prolonged intubations for years now since the pandemic. And this condition, unfortunately, is very, very hard to fix. There are a lot of surgical interventions that are often being tried, but the research is still developing on the best ways to treat PGI or PP, it's called PIPI, as related to only intubation. So very, very brief: vocal process granulomas, mobility impairments, laryngomalacia, papillomatosis, cancer, subglottic stenosis, as mentioned. All of these can impact the airway. Quick video here. I don't know if you've seen it on Instagram. Quick stroboscopy here. This patient, I was doing the strobe. Everything looked good. He was very stridorous. I'm seeing a wide open airway. I'm going to fast forward a little bit to get a little closer. Nothing I'm seeing that was worrisome. But the patient was seen for an in-office bronchoscopy right here with the laryngologist. And you can see in this video, there's an airway in the lower airway. And this is directly related to his symptoms. It was found he had a large goiter, and he, I think 2 weeks ago, had thyroidectomy. So again, the value of in-office bronchoscopy is truly for airway patients. It's really unmatched. This is a quick case I showed Brooke earlier, but this patient had a paralyzed vocal fold, but was getting no help from an implant from years ago. And we found via in-office bronchoscopy, her implant had migrated subglottically. So there's value to in-office bronchoscopy to really tell what's going on. And then this was revised in another surgery so that the implant then helped her voice. And just interesting things you might find as related to airway. Mucus can impact airway. Even pathologies can, because you're losing air, right? So you feel like you have to work harder for voice. As we know, rankies can affect airway because those swollen vocal folds can flip in and out of the airway. Granulomas can affect airway. And also papilloma, also cancer. Again, going through these quickly. Presbyophonia, thinning of the vocal folds. The person loses more air, so they have to work harder for their voice, right? They can't hold notes as long. And same thing with mobility impairments. This video just shows the value of an injection or thyroplasty as compared to airway. I'll just show it briefly. And you can see when the patient tries, she can never achieve that vocal fold closure. But then as that patient was injected, we can achieve that. So that can certainly help efficiency for voice. Most people may feel globus sensation. There's so many possible reasons to feel this, and I'm sure you hear that a lot from patients. Mucus tension, hypersensation, irritability, GI-related factors, dehydration, glottic insufficiency can cause globus, anatomical factors. So yeah, this can all contribute to airway as well. And this is one of the last videos. I like to show this because this patient had a constant tickle in his throat. But because of the scope, we did find out this was his uvula, that it was so long, it was touching his epiglottis and creating that tickle. So again, somewhat humorous because I got the little chuckle with the patient. But also, again, the value of using the scope for biofeedback as well and finding a reason for that tickle. So the value of scope for teaching is so important if you're able. Side note, and this was Dr. Todd Olin that said it, but no one cares how much you know until they know how much you care, right? So you do make a difference. And these are conditions that get very complex. And the more we know, the more we can help, the more we can advocate, we make such a big difference. And the patients really, truly feel that. So just kind of at the end here, reminding you to revisit your own mission. As a speech pathologist, you are in a helping profession, and I hope you chose it for that reason that we're here to help patients. We're here to help people. And with breathing, with voice, it's so, so important. And even if a laryngoscopy has been done, there's so much value in stroboscopy and even for airway patients. So think about, what is your mission? Why did you choose this profession? Because sometimes it's really helpful to revisit your why. Also knowing you could be the juiciest, ripest peach in the world, and there's still someone that hates peaches. I enjoy this quote because you cannot please everyone. It's true, but you can have good bedside manner and really try your best to advocate and help as many people as you can, and they certainly feel your energy and your passion. So it's great to revisit our mission, because this can often reignite us and keep alive our passion, because it's also easy to get burnout, right? So it's really important to revisit these things and never underestimate the ability you have to change someone's life, because in speech pathologists, we are in the business of changing lives. So I encourage you to prioritize your voice and consider these airway conditions, these airway patients. They need our help. And I know this was quick, and I do have a more comprehensive course that I've now developed because of doing this presentation for you. That's really, really comprehensive, and it'll be out here soon. So if interested, I encourage that. If there's any time for questions, I'm totally open to it. These are my references, and I will stop sharing in this moment. Thank you so much for listening, everyone.
Sara, you're amazing. Everyone is commenting in the chat about how outstanding this presentation was and how they would love to take your comprehensive course. One of the questions I saw was regarding your equipment. An attendee was interested in knowing what equipment you're using in office.
So I work at an ENT private practice with laryngologists. So we have Pentex equipment, which used to be called K-Pentex. So it's basically endoscopy and video stroboscopy, in-office bronchoscopy options, etc. But whatever visualization you're able to use, if that's what you're talking about, any kind of scope that allows you to visualize the larynx is honestly what you need. If the patient has zero voice concerns, which can be rare, you may not need a stroboscopy. If it's me, I'm always advocating for that personally, because there's so much value in seeing the vibratory parameters, and you can get a lot better detail than with just a basic scope. And really, my suggestion if you're doing scoping is to get as close as you can and use certain scoping techniques that allow that. One I would just offer, ask the patient to phonate for 10 seconds and get as close as you can to the cords to really get detail. And then also have the patient lift the chin a little bit and really get a nice, slow, easy breath in, and really encourage them easy nasal breathing. Get as close as you can to the airway, to the cords as possible. And I always remember Dr. Blake Simpson saying, you paid for those pixels, get that picture, get as close as you can, because it's really, really important, because we have that ability, if you're trained, to really get those pictures. And it really doesn't lie and tells a story. It can help the patient believe, as we mentioned. Hopefully that answers the question.
Yes, definitely. Now there's a follow-up question about scoping. Alan asks, where did you learn all of your scoping techniques?
So, long story short, basically there are several courses you can go to in the whole nation that are in person for fees for video stroboscopy. There are online versions. There's training on the Valley R, which is what I highly recommend if you're doing video stroboscopy. There's one on Northern Speech. I also have one myself. There's a lot of stuff you can read. There's more conferences you can go to. There's clinical kind of mentoring programs where you're learning all the details of that. And there's still so much value in your own furthered education with becoming a pro at what you're doing. It's so, so important. And I would just say through trial and error and constant learning is how I kind of learned all the details of all the different techniques and the variability you can use, how to keep the patient calm, the benefit of doing breathing stuff, airway patients with scopes. In a nutshell, that's what I would tell you. But there's, all that you can do to advocate for your own education. And who knows, it could reignite your passion as well. It's so important to keep learning and progressing, because we should never be stagnant. We can always be learning with research, conferences, trainings. There's always more, and not in a way that should hopefully sound, not bogging you down, but invigorating you to learn more, because there's so much we can do. And to be honest, we can advocate for our patients sometimes more than physicians can, often more. And so I really think there's value in being that person or providing them that visual or that information or that technique that can make a huge difference when they've been relying more on medication for years or whatever else.
Sarah asked, what is the average number of sessions needed for a patient with ILO or EILO?
Yeah, great question. So again, I had to go fast through therapy stuff, but there's a lot more to that. But I would tell you in a nutshell, airway patients are quick. So our cough patients, if they do their job and you do yours, it's quick. It needs to be consistent, persistent practice. But if they're bought in and they do it and you're doing it, I mean, honestly, one session makes a huge difference, but it could be 1 to 4, and to be honest, in the voice therapy literature, 4 is established the magic number of sessions. 4. We should be able to give them tools. Now, again, this is very different than like LSVT. This is different than dysphagia therapy, etc. But for airway, 1 to 4, probably not 4, probably 1 to 2, max of 3. If they're doing the work and you are too, voice 4 is a good number. It all depends what's going on, of course. And just remember too, we want to know, is surgical intervention required? Because it very well could be, in which case we can still help because, before they have a surgery, we can help with techniques just to keep them as calm as possible. I can think of one lady who was actually in her 90s. She was found to have that posterior glottic stenosis, so it looked like bilateral paralysis. It was a really sad case. And she actually did not want to trach. And, patients make their own choices. We are not ever going to ever force something, even if we think, oh my gosh, you need this airway. What if you can't breathe in the middle of your sleep and that's how you die? But all we do is educate. And that's what the laryngologist did. And the patient did not want to trach. She didn't want surgery. So I was there to help her learn techniques to keep her as breathing easy as she could and learn techniques. And I focused a lot on nasal and full body and helped her. And she actually randomly, I got a card from her and she's doing great. And she hasn't had surgical intervention yet. And she found another book besides the one I recommended. And she's all into breathing things now. And that could be a blessing, or that could be a random case. But I still think there's value in us helping these patients, even when surgical intervention is required. And maybe that could be afterwards because they could be stuck in these patterns that are not as efficient as they could be. And that's also where you can come into.
Amazing. I'll ask you one more question. An attendee asked whether or not you use EMST in your practice.
Yes. So as in respect to the resistance training for breathing, which I will always use with breathing pattern disorder, respiratory muscle training, this is more resistance training. This would be the breather voice, the breather fit. I pretty much never use the regular breather. This could be the Buteyko belt. This could be a stretchy band here. This could be your own hands or the patient's hands. This could be any kind of mirror. This could be feedback like that, but resistive training is so important because it provides feedback. It brings the mind lower down. It gives something to breathe into. That's also where the straws come in. But EMST, yes, more yes. I love EMST. For ILO, ELO patients and breathing pattern disorder patients, I would say I use it slightly less. I use it a lot with voice patients, with people who, maybe have more neurological diagnoses or Parkinson's, presbyophonia, weakness. But you likely know in EMST, there's research on people who completely are normal, but are singers, public speakers, swimmers, athletes that just want stronger breathing. And I tell people all the time. And so if they come to me and they want a stronger voice, no matter what age or condition, or even if they're perfect, I say it's a good idea because I have one myself. It's right here in my office. And so is the breather voice, and so is vocal mist. So like all these things I do myself as well. And I did EMST personally for 3 years, and I want to restart it because there's always value, like that statistic about lung capacity and expansion being directly correlated to length of life in years. Why aren't we all strengthening all that, right? So yes, on EMST for sure, but for these airway patients, I will start a little more with resistive muscle training, pattern training against resistance. And again, it's on the inhale and the exhale. And I know you can get an IMST and you can get the adapter for the EMST, but again, for airway, focus a little more just resistance first. And then once they overcome the airway condition or the breathing pattern disorder, I always tell them there's ways you can further strengthen. That could be EMST, that could be the power breathe, the power lung. There's several options, and some of those are even more at the Olympic level too.
Well, Sarah, I can't thank you enough for your expertise this evening. And I know there were a lot of questions in the chat about the recording and the slides. So just a recap, this will be posted on the TIMS website under the TIMS University tab on the on-demand page. And we will link to several resources, including Sarah's website. As I mentioned, she has a ton of incredible resources on her website, and you should definitely follow her on social media because she provides a lot of this information complimentary on her Instagram. But as she said, she's going to be providing this as a comprehensive course through her website. So that will also be linked on the TIMS website. So you can check that out and learn more there. So again, thank you, Sarah, for being with us this evening. If anyone is wanting ASHA CEUs, that survey link will be sent out via Zoom email here in a couple of minutes. And if you have any questions, feel free to email us at tims-unum@tims.com. Thank you all so much. And thanks again, Sarah.
Thank you, everyone. Thanks for coming. Happy Monday.
Bye, everybody.